The modern family nurse practitioner stands at the crossroads of physical and mental wellness. In the busy setting of primary care, patients arrive with a host of complaints, from a persistent cough to chronic back pain. Yet, interwoven with these physical symptoms are often the subtle and sometimes overt signs of mental health distress. Recognizing this connection is no longer a specialty reserved for psychiatrists. It is a fundamental competency for every primary care provider. The family nurse practitioner is uniquely positioned to be the first point of contact, the trusted professional who can identify a developing mental health condition, initiate care, and provide a bridge to more specialized services when necessary. This gatekeeper role carries immense responsibility and opportunity. Understanding psychiatric mental health is not merely about memorizing diagnostic criteria for an exam. It is about cultivating a deeper empathy and a more holistic perspective on patient care. A patient presenting with fatigue and unexplained aches might be suffering from a vitamin deficiency, or they might be experiencing the somatic manifestations of major depressive disorder. Similarly, a patient with recurrent gastrointestinal issues could have an underlying eating disorder that has gone unnoticed. Without a strong foundation in mental health, these critical diagnoses can be missed, leading to prolonged suffering and ineffective treatment plans. Effective family nurse practitioner practice, therefore, demands a dual-focus lens, one that sees the person as a whole, acknowledging that the mind and body are inextricably linked. This essay serves as a foundational guide for family nurse practitioner students preparing for their certification exams and for their future practice. We will explore several of the most common psychiatric mental health conditions encountered in the primary care setting. These include depression, anxiety disorders, eating disorders, the consequences of abuse, alcohol use disorder, insomnia, and the challenges of smoking cessation. For each condition, we will review the essential signs and symptoms, discuss the basics of diagnosis using established criteria, and outline the first-line treatment approaches that a family nurse practitioner can confidently initiate. The goal is to demystify these topics, making them accessible and manageable. Ultimately, mastering this material is about more than passing a test. It is about building the confidence to ask difficult questions, to listen with an open mind, and to provide care that is both evidence-based and profoundly compassionate. As a family nurse practitioner, you will be a source of stability and hope for countless individuals and families. Your ability to adeptly navigate the complexities of mental health will be one of the most powerful tools in your clinical arsenal. This knowledge empowers you to not only treat disease, but to truly promote health in its fullest sense, fostering resilience and well-being in the communities you serve. Major depressive disorder is far more than simply feeling sad. It is a persistent and pervasive illness that affects mood, thought processes, and physical health. The key to recognizing it in a clinical setting is understanding its core symptoms, often remembered by the mnemonic SIDCAPS. This stands for changes in sleep, either insomnia or hypersomnia, loss of interest, what we call anhedonia, feelings of guilt or worthlessness, decreased energy or fatigue, poor concentration, changes in appetite, which could be weight loss or gain, psychomotor agitation or retardation, and suicidal ideation. For a diagnosis, a patient must exhibit at least 5 of these symptoms, including a depressed mood or anhedonia, for a minimum of 2 weeks. These symptoms must cause significant distress or impairment in social, occupational, or other important areas of functioning. Diagnosing depression in a primary care setting begins with screening. Tools like the Patient Health Questionnaire 9, or PHQ-9, are invaluable for quantifying symptom severity and monitoring treatment response. The PHQ-9 is a simple 9-question tool that directly corresponds to the DSM-5 criteria for major depressive disorder. A score of 10 or higher suggests a moderate level of depression and typically warrants further evaluation and potential treatment. It is also crucial to rule out any underlying medical conditions that can mimic depression, such as hypothyroidism, vitamin B12 deficiency, or anemia. Therefore, a basic laboratory workup, including a complete blood count, a comprehensive metabolic panel, and a thyroid-stimulating hormone level, is a standard part of the initial assessment. First-line treatment for mild to moderate depression in adults is typically a combination of psychotherapy and pharmacotherapy. Selective serotonin reuptake. Inhibitors, or SSRIs, are the most commonly prescribed class of antidepressants due to their favorable side effect profile and safety. Examples include fluoxetine, sertraline, and escitalopram. When initiating an SSRI, it is vital to educate the patient that it may take 4 to 6 weeks to experience the full therapeutic effects. Common side effects can include nausea, headache, and sexual dysfunction, many of which may subside over time. Close follow-up is essential, particularly within the first few weeks, to monitor for side effects and assess for any increase in suicidal thinking, which is a black box warning for adolescents and young adults. A crucial clinical pearl for family nurse practitioner students is the start low, go slow principle when prescribing antidepressants, especially in older adults or patients with comorbidities. Begin with the lowest effective dose and titrate upwards gradually based on the patient's response and tolerance. Another important tip for exams is to remember to screen every patient with depressive symptoms for suicidality. A direct question such as, "Have you had any thoughts of harming yourself?" is essential for patient safety. Documenting this assessment is equally critical. Finally, always involve the patient in treatment decisions, discussing the pros and cons of medication versus therapy to foster a strong therapeutic alliance and improve adherence to the plan. Eating disorders are serious psychiatric illnesses characterized by severe disturbances in eating behaviors and related thoughts and emotions. The 3 most common types encountered in primary care are anorexia nervosa, bulimia nervosa, and binge eating disorder. Anorexia nervosa is defined by a restriction of energy intake leading to a significantly low body weight, an intense fear of gaining weight, and a disturbed perception of one's own body weight or shape. Bulimia nervosa involves recurrent episodes of binge eating, consuming a large amount of food in a discrete period, followed by compensatory behaviors like self-induced vomiting, misuse of laxatives, or excessive exercise. Binge eating disorder is similar but lacks the compensatory behaviors, leading to feelings of guilt and distress and often obesity. Diagnosing an eating disorder requires a high index of suspicion and sensitive questioning. Patients rarely self-report these behaviors due to shame and denial. Clues may emerge from a review of systems or physical exam. For instance, a patient with anorexia may present with amenorrhea, bradycardia, or lanugo, which is fine, soft hair. A patient with bulimia may have dental enamel erosion from vomiting, sialadenosis, or swollen salivary glands, or Russell's sign, which is calluses on the knuckles. Screening tools like the SCOFF questionnaire, which asks about making oneself sick, loss of control, losing 1 stone, feeling fat, and food dominating life, can be a quick and effective way to open the conversation. A thorough history should include questions about eating patterns, body image, and exercise habits. The first-line approach to managing eating disorders is multidisciplinary, involving medical, nutritional, and psychological care. For the family nurse practitioner, the initial priority is medical stabilization. This involves assessing vital signs, obtaining an electrocardiogram to check for arrhythmias like a prolonged QTc interval, and ordering laboratory tests to check for electrolyte imbalances, especially hypokalemia and bulimia, and signs of malnutrition. The primary treatment for all eating disorders is psychotherapy, with cognitive behavioral therapy being the most evidence-backed approach, particularly for bulimia and binge eating disorder. For anorexia, family-based therapy is often the most effective intervention for adolescents. Pharmacotherapy can be an adjunct. For instance, fluoxetine is FDA approved for bulimia nervosa. A critical clinical pearl for family nurse practitioners is to be aware of refeeding syndrome in severely malnourished patients with anorexia. When nutrition is reintroduced too quickly, a rapid shift in fluids and electrolytes, particularly phosphate, potassium, and magnesium, can occur, leading to potentially fatal cardiac, pulmonary, and neurological complications. Therefore, realimentation must be started slowly and cautiously, often in a hospital setting. For exams, remember that while SSRIs are used for bulimia, they are generally not effective for the core symptoms of anorexia until weight restoration has been achieved. The family nurse practitioner's role is often to identify, stabilize, and refer to a specialized treatment team while continuing to manage the patient's primary care needs. Anxiety becomes a disorder when it is excessive, persistent, and interferes with daily life. Generalized anxiety disorder is one of the most common forms seen in primary care. It is characterized by at least 6 months of chronic, exaggerated worry and tension about a variety of everyday problems. The symptoms are not just mental, they often manifest physically. Patients may complain of fatigue, restlessness, difficulty concentrating, irritability, muscle tension, and sleep disturbances. These physical complaints are frequently the reason they seek medical attention, making it essential for the family nurse practitioner to consider an anxiety disorder in the differential diagnosis for patients with vague, multisystemic symptoms that lack a clear organic cause. The diagnostic process for generalized anxiety disorder involves a thorough clinical interview to assess the nature and duration of the worry. The generalized anxiety disorder. 7-item or JADI-7 scale is a highly effective and efficient screening tool. It helps to quantify the severity of anxiety symptoms and can be used to track progress over time. A score of 10 or greater on the JAD-7 is a reasonable cut point for identifying cases that may need intervention. As with depression, it is important to rule out medical conditions that can cause or exacerbate anxiety, such as hyperthyroidism, cardiac arrhythmias, or substance withdrawal. A careful review of medications is also necessary, as substances like caffeine, decongestants, and certain asthma medications can contribute to feelings of anxiety. First-line treatment for generalized anxiety disorder, much like depression, involves a combination of psychotherapy and medication. Cognitive behavioral therapy is highly effective, as it teaches patients to identify, challenge, and reframe the negative thought patterns that fuel their anxiety. In terms of pharmacotherapy, SSRIs and serotonin norepinephrine reuptake inhibitors, like venlafaxine and duloxetine, are considered the gold standard. They are preferred for long-term management due to their non-addictive nature. It is important to counsel patients that these medications can initially increase anxiety for a week or two before the therapeutic effects begin, a phenomenon that requires reassurance and close monitoring. A key clinical pearl is to use benzodiazepines, such as lorazepam or alprazolam, with extreme caution. While they can be effective for short-term relief of severe anxiety, they carry a high risk of tolerance, dependence, and withdrawal. They are best reserved for short-term use, like 2 to 4 weeks, as a bridge until an SSRI or SNRI becomes effective, or for managing acute panic attacks. For exam purposes, know that buspirone is a non-benzodiazepine anxiolytic that can be a good option for generalized anxiety disorder. But it is not effective for panic disorder and takes several weeks to work. Always educate patients on non-pharmacological strategies like exercise, mindfulness, and sleep hygiene, which are foundational to managing anxiety. Abuse, whether it is intimate partner violence, child abuse, or elder abuse, is honestly a significant public health issue that family nurse practitioners are in a prime position to identify. It can show up in physical, emotional, sexual, or even financial forms. The signs, though, are often pretty subtle and can be easily missed if we're not actively looking for them. Patients might come in with injuries that just don't match the explanation given, like bruises in various stages of healing or in places that are typically protected, such as the torso or neck. Other red flags to look out for include frequent visits for somatic complaints, like headaches or chronic pain, symptoms of depression or anxiety, delayed seeking of medical care, or sometimes a partner who is overly controlling and insists on being present for all appointments and speaking for the patient. Screening for abuse really should be a universal practice, done privately and in a non-judgmental way. Simple, direct questions can actually be very effective. For example, using a tool like the HITS, Hurt, Insult, Threaten, Scream screen, can open the door to disclosure. A provider might say, "Because violence is so common in many people's lives, I've started asking all of my patients about it." This helps normalize the question and reduces stigma. When it comes to children, observing the parent-child interaction can provide important clues. For older adults, signs of neglect, like poor hygiene, malnourishment, or untreated medical conditions, should raise immediate concern. The family nurse practitioner really needs to be attuned to both verbal and nonverbal cues. The first-line response to a disclosure of abuse is to validate the patient's experience and make their safety the top priority. The immediate goals are to express belief, offer support, and conduct a thorough safety assessment. This includes asking direct questions about the severity and frequency of the violence, the presence of weapons in the home, and whether the patient feels safe returning home. It's not the provider's role to rescue the patient, but instead to empower them with information and resources. This includes providing contact information for local domestic violence shelters, hotlines like the National Domestic Violence Hotline, and legal aid services. Careful and objective documentation is absolutely paramount, using direct quotes from the patient whenever possible. A critical clinical pearl is understanding your legal and ethical obligations as a mandated reporter. Family nurse practitioners are legally required to report suspected cases of child abuse and elder abuse to the appropriate state agency, such as Child Protective Services or Adult Protective Services. The laws regarding reporting intimate partner violence for competent adults do vary by state, but the focus is generally on patient safety and autonomy, rather than mandatory reporting. For exams, it's important to know the key indicators of abuse for different age groups and the importance of a safety plan. A safety plan might include practical steps like having a bag packed with essentials, identifying a safe place to go, and creating a code word with a trusted friend or family member. Alcohol use disorder, or AUD, is a chronic relapsing brain disease that's marked by an impaired ability to stop or control alcohol use, even when it's causing social, work, or health problems. It actually exists on a spectrum, ranging from mild to severe. Some of the key symptoms include a strong craving for alcohol, a loss of control over drinking, developing a tolerance, which means needing more alcohol to get the same effect, and experiencing withdrawal symptoms if use is stopped or reduced. In a primary care setting, patients might not come in saying they're drinking too much. Instead, they might show up with related medical issues like high blood pressure, gastritis, pancreatitis, elevated liver enzymes, or even sleep disturbances. This is why screening is such a crucial part of routine care. Diagnosing AUD involves using standardized screening tools, followed by a more detailed assessment based on the DSM-5 criteria. A quick and pretty effective initial screen is the single question screen. How many times in the past year have you had 5 or more drinks in a day for men or 4 or more for women? If the answer is positive, that means it's time to use a more in-depth tool, like the audit, the Alcohol Use Disorders Identification Test. The DSM-5 outlines 11 criteria for AUD, and the severity is determined by how many criteria are met. Mild if it's 2 or 3, moderate if it's 4 or 5, and severe if it's 6 or more. It's also really important to assess the patient's readiness to change, since that will guide the therapeutic approach. First-line treatment for AUD is multifaceted and should be tailored to the individual. For patients who are ready to reduce their drinking or quit altogether, evidence-based behavioral therapies and FDA-approved medications are the cornerstones of care. Medications can help manage withdrawal, reduce cravings, and support abstinence. Naltrexone, which can be given orally or as a long-acting injection, is a great first-line option because it reduces both the rewarding effects of alcohol and cravings. Acamprosate helps restore the brain's chemical balance and works best for patients who have already stopped drinking. Disulfiram, or Antabuse, causes an unpleasant reaction to alcohol and is really only for highly motivated patients. These medications are most effective when combined with counseling or support groups like Alcoholics Anonymous. A vital clinical pearl for nurse practitioners is to be able to recognize and manage alcohol withdrawal, which can actually be life-threatening. Withdrawal symptoms usually begin 6 to 24 hours after the last drink and can range from mild anxiety and tremors to seizures and delirium tremens. The Clinical Institute Withdrawal Assessment for Alcohol, or CIUA-R scale, is used to measure the severity of withdrawal and guide treatment, usually with benzodiazepines. For exams, it's essential to know the first-line medications for AUD, naltrexone and acamprosate, and how they work. Also, remember that Wernicke-Korsakoff syndrome, a neurological condition caused by thiamine deficiency, is a serious complication of chronic alcoholism. So, thiamine supplementation should be given to at-risk patients and always before giving glucose. Insomnia is a really common sleep disorder, and it's defined by persistent difficulty with falling asleep, staying asleep, or getting good quality sleep. This happens even when someone has plenty of opportunity to sleep, and it leads to daytime problems like fatigue, mood changes, or trouble thinking clearly. Chronic insomnia is when these symptoms occur at least 3 nights a week for at least 3 months. In the family nurse practitioner's office, insomnia is a frequent complaint, and it's often linked to other medical or psychiatric conditions. It can be a symptom of depression, anxiety, or chronic pain, but it can also be a primary disorder all on its own. A thorough evaluation is needed to uncover what's really going on. The diagnosis of insomnia is mostly based on the patient's history. Getting a detailed sleep history is the most important diagnostic tool. This should include questions about bedtime routines, the sleep environment, how long it takes to fall asleep, nighttime awakenings, and how the person functions during the day. Asking the patient to keep a sleep diary for 1 to 2 weeks can give really valuable, objective information about their sleep patterns. It's also critical to screen for other sleep disorders that might look like insomnia, such as obstructive sleep apnea, so ask about snoring, gasping, and daytime sleepiness. And restless leg syndrome, which is an uncontrollable urge to move the legs, especially in the evening. Ruling out other factors, like caffeine intake, alcohol use, or certain medications, is also a key part of the workup. The gold standard first-line treatment for chronic insomnia isn't medication, but cognitive behavioral therapy for insomnia, or CBTI. CBTI is a structured program that helps patients identify and change thoughts and behaviors that make sleep problems worse, replacing them with habits that promote better sleep. Its components include sleep hygiene education, stimulus control, which means reassociating the bed with sleep, sleep restriction, which limits time in bed to the actual time spent asleep, and cognitive therapy to reframe negative thoughts about sleep. While CBTI is highly effective, access can sometimes be a barrier. Thankfully, digital CBTI programs are becoming more available. A crucial clinical pearl is to avoid routinely prescribing sedative hypnotic medications, often called Z-drugs like zolpidem or azopiclone, for long-term insomnia management. They can be effective for short-term use, but they're associated with risks like tolerance, dependence, and side effects such as next-day impairment and complex sleep-related behaviors. For exams, you absolutely need to know that CBTI is the gold standard for first-line treatment. If medication is considered for short-term use, options like low-dose trazodone, which is a sedating antidepressant, or ramelteon, a melatonin receptor agonist, may be safer alternatives to traditional hypnotics, especially in older adults. And always start with sleep hygiene education as the foundation of any treatment plan. Tobacco use is still the leading cause of preventable death and disease in the United States, which makes smoking cessation a top priority in primary care. Nicotine is a highly addictive substance that creates both physical and psychological dependence. As family nurse practitioners, our role starts with identifying every patient who uses tobacco and assessing their willingness to quit. The cycle of addiction is powerful, and most patients will need several quit attempts before they achieve long-term success. It's important to approach this conversation with empathy and persistence, understanding that quitting is a process, not a one-time event. Presenting the health risks does matter, but honestly, focusing on the benefits of quitting can be an even stronger motivator. The 5 A's model is a simple, evidence-based framework for counseling patients on smoking cessation. This model includes: ask about tobacco use at every visit. Advise all tobacco users to quit in a clear, strong, and personalized way. Assess their willingness to make a quit attempt. Assist them in their quit attempt by providing counseling and recommending pharmacotherapy. And arrange for follow-up contact to support them. This structured approach really helps make sure tobacco use is consistently addressed and that patients are offered concrete help. Assessing the level of nicotine dependence, like asking how soon after waking they have their first cigarette, can help tailor the treatment plan. First-line treatment for tobacco dependence involves a combination of behavioral counseling and FDA-approved pharmacotherapy. There are 3 main classes of medication: nicotine replacement therapy, or NRT, bupropion, and varenicline. NRT products, patch, gum, lozenge, inhaler, nasal spray, help relieve withdrawal symptoms by providing nicotine without the harmful toxins of tobacco smoke. Bupropion is an antidepressant that reduces cravings and withdrawal symptoms. Varenicline works by blocking nicotine receptors in the brain, which reduces both the pleasurable effects of smoking and withdrawal symptoms. Combination therapy, like using the nicotine patch for baseline control and the gum or lozenge for breakthrough cravings, is often more effective than using a single agent. A key clinical pearl is to proactively address patient concerns about medications. For varenicline, it's important to counsel patients about the potential for nausea, which can be lessened by taking it with food and a full glass of water, and to discuss the past warnings about neuropsychiatric side effects, noting that large studies have shown it doesn't have a significantly higher risk than placebo. For exams, know the different types of NRT, and remember that combination NRT is often the most effective. Also, be sure to set a quit date with the patient, usually 1 to 2 weeks after starting medication like varenicline or bupropion, so the drug has time to reach therapeutic levels. Consistent follow-up is really the key to success. As we've journeyed through these common psychiatric mental health conditions, a clear and compelling picture really emerges. Mental wellness is deeply woven into the fabric of primary care. The family nurse practitioner doesn't have the luxury of seeing the mind and body as separate. The patient with chronic fatigue might actually be battling depression, the teenager with weight changes could be hiding an eating disorder, and the older adult with lots of physical complaints might be suffering from profound anxiety or the silent trauma of abuse. A strong, practical understanding of these conditions isn't just an extra skill. It's a core competency that defines excellent, holistic, and patient-centered practice in today's world. This review has aimed to simplify these complex topics, providing a clear path through symptoms, diagnosis, and first-line treatments. From using screening tools like the PHQ-9 and JAD-7 to applying the 5 A's for smoking cessation, these evidence-based strategies are designed to fit into the fast-paced primary care environment. The clinical pearls offered for each condition, like starting low and going slow with antidepressants, prioritizing safety in cases of abuse, and recognizing CBT-I as the gold standard for insomnia, are meant to be memorable anchors of knowledge for both your certification exam and your daily clinical decision-making. These are the practical tools that build confidence and ensure safe, effective care. The responsibility of a family nurse practitioner is immense, but so is the opportunity to make a profound difference. You are often the first and sometimes the only healthcare provider a patient trusts enough to confide in. Your ability to listen with empathy, to screen with intention, and to intervene with knowledge and compassion can truly change the trajectory of a person's life. It can be the first step on a path to recovery from addiction, the first moment of validation for a victim of violence, or the first ray of hope for someone lost in the shadow of depression. This is the art and science of nursing at its finest. So as you prepare for your exams and look forward to your career, embrace this vital aspect of your role. Let this knowledge empower you not just to answer questions correctly, but to ask the right questions of your patients. See every encounter as a chance to assess the whole person. By integrating mental health care seamlessly into your practice, you become more than just a treater of symptoms. You become a true healer, a trusted advocate, and a cornerstone of health and well-being for the individuals, families, and communities you serve. Your expertise in this area is a gift, one that will benefit your patients for a lifetime.